Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider.
Welcome to the Untethered Podcast. I'm your host, Hallie. I'm a certified orofacial myologist, feeding specialist, SLP, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, tethered oral tissue, and airway space. I challenge you to keep an open mind and join my mission to get this information out to the masses. Let's get started.
Hi, and welcome to episode 54 of the Untethered Podcast. Today, we have Dr. Howard Hindin joining us. Howard has been in practice for over 50 years. His practice, the Hindin Center for Whole Health Dentistry, focuses on sleep, airway, TMJ, and craniofacial pain, oral systemic conditions, as well as restorative and cosmetic dentistry. He is the president of the AAPMD, American Academy of Physiological Medicine and Dentistry, and the founder and director of the Foundation for Airway Health. He and Michael Gelb authored GASP, Airway Health, the Hidden Key to Wellness. Dr. Hindin is one of the creators of Collaboration Cures and is a passionate advocate for interdisciplinary collaborative care and for the patient being a partner in the process. Howard, thank you so much for joining us on the podcast today. I'm excited to talk to you.
And I'm happy to be here. We have a lot of downtime, and why don't we use it well?
Absolutely. And I think just based on what's going on in the world, obviously we have a lot of good information to impart on our colleagues. So let's talk about the elephant in the room. Let's talk about COVID-19 and see what we have to offer.
Well, like you with your podcast, we with the AAPMD, I've been doing a lot of webinars, and the thing that people want to hear most about is COVID, which is something that none of us have experienced in a lifetime. I happen to be older, so I remember my parents telling me about the Spanish flu of 1918. Actually, my mother lost one of her sisters who was late teens as a result of the flu. And as a result of that, she always had this concern: wash your hands, don't touch anything. You had to eat the right foods, you had to get enough sleep, because there was this fear that if you got sick, there wasn't anybody that was going to save you, that you could die. So taking care of your health was your responsibility. And so before I went to dental school, I was a history major. And so I love history. So looking at the history of medicine and dentistry, we went through that period of fear, and then World War II came along, and we discovered penicillin. Penicillin changed the whole world of pharmaceuticals. Before penicillin, there were very few drugs. Nothing sold a lot. You went to a pharmacist, and they took a mortar and pestle, and they mixed. But two, fast forward, all these drugs got created for you name it. In fact, I'm just reading, COVID Downtime provides a lot of time for reading. I'm reading a book called Pharma, which is how the pharmaceutical industry grew. And so there was this belief that no matter what happened, there would be a procedure or a medication that would solve that problem, and we became more or less reliant on drugs. In fact, today, when somebody goes for a medical visit, the first thing they do is they ask for the insurance card. It's not about the care; it's about who's going to pay for it and how it's going to be paid. So we move from a period of maybe 100 years ago, where there was fear that something could happen and threaten the lives of your life, the life of your family, to this feeling like, well, things would never happen that would be bad, and if they happen, our medical system would take care of it. So what are the lessons that we've learned from our COVID experiences is, one, that our healthcare system is very disorganized, that we have government doesn't talk to the pharmaceutical industry, and hospital systems. They don't talk to each other. So there's complete lack of coordination, or to use my favorite word, collaboration. And now they're scurrying, and now people from one state are sending masks to New York when they need it. And that's the way it should be. There should be more collaboration. And the other deficit of the COVID crisis was a lack of stockpiling, that we didn't put away things for the future. We didn't have enough masks. We didn't have enough ventilators. We didn't put away things for a rainy day. So how do we put this in terms of my thinking? Because for about 5 years when we started this Collaboration Cures movement, that in order to provide optimal care and wellness, there needs to be collaboration. No one discipline, no one practitioner has all the answers. We often delude ourselves because we get somebody with a problem. You or another myofunctional therapy do what you do. I can treat somebody's airway dentally, an integrated physician could treat somebody nutritionally, and the patient will always get better. And we're happy, the patient's happy, but have we provided optimal care? Do we know what other piece of the puzzle is missing? My analogy is to a race car, or any car. Car goes over a bump and the frame gets bent and the car doesn't ride properly. The tires wear out, you fix the tires, or you fix the brakes, but it's still not right because you haven't gotten down to the core structural problem and treated that. So that's one area is collaboration. The second area is stockpiling. What we need to do is stockpile our internal resources, the things that will make our immune system better. We have this incredible immune system that protects us. It works 24/7, never even talks to us, never asks us for anything, doesn't ask for a pay raise, doesn't ask for a vacation. It works. And it's not a question of our immune system fighting a problem, it's fighting it correctly. You don't want it to underreact, and you don't want it to overreact. And it has two stages, which everybody's probably heard about. One is the innate immune system, which as soon as it recognizes an enemy, it will respond. And then when it learns what that particular attacking agent is, it develops an adaptive immune system where it responds secondarily. So one of the problems with COVID is it's not the disease that gets you, it's the immune system. It's our immune system is overreacting. It keeps sending out troops, more troops than is needed. There's a drunk on the corner. You don't need to send out an army. You could send out one police car and tell them to go home. But sometimes our immune system doesn't work like that. So why is it important to us? Is because all the things that we do, all the people who are in our Collaboration Cures movement who are really interested in getting down at the cause of the problem have the ability to make the immune system better. Not necessarily stronger, but it's called modulating the immune system, so it mounts to appropriate response to whatever is going on. There's a great interview with a public health doctor. His name is David Katz, who talked about how we don't look at these chronic diseases because how our immune system fails or doesn't respond is related to all the chronic diseases we have. You may not know how many cases of diabetes we have in our country, 122 million people. They say by 2040, 50% of the people in this country will either be diabetic or pre-diabetic. You had cardiovascular disease, dementia, cognitive loss, and other things. These are all related to chronic inflammation and our immune system. The problem with that is the harm that occurs, the risks that occur going back to childhood, you don't see the problem until decades later. And when you don't see it, you can't connect it. And so, try to tell a kid that, the things you take care of today will pay dividends tomorrow. They don't want to hear it. I didn't want to hear it when I was that age. But now with COVID, you get sick, and 80 or more % of the people have no effect. They don't even know they had it. They walk around, maybe they feel sick for a day. And there are the other people, the aged, the sick, and those with comorbidities. And what are the comorbidities? The same ones we just talked about. They're the ones who are at risk and die. I think 80 or 90% of people who go on ventilators ultimately die. And so one of the lessons is we have the power to change our immune system, and it really starts in childhood, because every stress that is put into our body that we come across, we have to adapt, or maybe not adapt to, we compensate for. And every compensation pays a price. And so that this gives us the opportunity to, one, look how we really all connected and work better together. And two, work together to stockpile our resources, our internal resources, so that our immune system is ready for whatever attack comes along. And then there's talk that maybe we haven't exercised our immune system enough. In the Amish country, where the mothers take their young babies into the barn while they milk the cows and the babies sit on the floor of the barn, they have almost no autoimmune diseases in their population. So maybe we're being overprotective. These are things we have to look at. So I'm optimistic because it's a terrible thing. The news is terrible. What do we do? How do we get people back to functioning? Because now we're beginning to see the problems of people being out of work, not having money to buy the right food, the stress that it causes, and people begin to lose sleep. Now we don't know the problems caused by I think everybody has COVID, whether you have the disease or you suffer from the spread of whatever's happening about disease. Everybody's affected by it one way or another. So that's my little COVID background, and I'm sure that you can sort of resonate with this a bit.
Yeah, absolutely. And I think, obviously, I would absolutely agree that everybody has been affected in one way or another, whether it's health-wise or the mental health, the stress. I mean, obviously that's health too, the financial burden, just the new normal that everybody's experiencing right now. But I think that what it comes back to, and what we've really been trying to focus on over here, is still that patient-centered care for the people in our practice, and just reaching out to everybody we know, to check in on everybody and make sure from a mental health standpoint, in addition to physical health, immune system health, everybody is affected, and it's going to take a toll one way or another. And the faster we can get back to whatever our new normal is, the better. But what is your take on that in terms of return to some sense of what everyone considers normalcy or new normalcy?
Well, there will be a new normal. And I think that certainly I can talk from the dental perspective, that I think that those people who look at more of the total health, mm-hmm. Will thrive better in this world. What we've started calling our patients, and we ask them a question like, how likely are you to come for an appointment? Some say, as soon as you're open, I'm ready to come in. And some other people say, maybe a year, but I'm not even leaving my house for a year, let alone going to dental office. And the CDC said, don't go to the dental office unless it's emergency, because that could be the most dangerous place to be, with all the aerosol spraying around. So now what we've done in the last weeks is dental offices only have open rooms with no doors. We put doors on all the rooms. We put HEPA filters in all the treatment rooms. We have defoggers using hypochlorous acid that they use in emergency rooms. We have shields over our masks, and and then we looked at, do you have a level 2, a level 3, and an M95? What mask? M95 masks, which were $1 or less, and now some companies are selling them for $8. If you can get them, and what can you do? And they say maybe dental hygienists won't be able to use their ultrasonic cleaner. So what can you do? So one of the things we talked, and then the other issue, I mean, if you ever think about a dental office, dentist is working, hygienist is working, the patient says, I need to have an exam. So dentist has to get up and go in and do the exam. So now that we're gowned and gloved and shielded and we have to take us off our stuff, go into the hygiene room, re-gown, re-glove, do the exam, and then go back and reverse it, which is time-consuming, using supplies. So one of the suggestions is the hygienist takes all the information, takes photos, does a little video of the mouth, even can do a recording of what's bothering the patient, records all that data. Dentist never goes in and goes back later, and on a Zoom call does the examination there. So, well, we don't know how that'll work. On the one hand, maybe the patient may say, I didn't see the dentist, I just had the hygienist, but hygienist is spending an hour with the patient. Dentist runs in for 5 minutes maybe, and is thinking about getting back to the other room where they were working, talks to the patient with their mouth open, asks them questions while they're examining them. It might be a much better experience if you're sitting facing somebody like I'm facing you, and I can put up all your x-rays, and that might be a better educational moment, because the goal isn't to have people come in for repair. The goal is to make people not need you. If you're a good doctor, you should struggle having patients, because everybody you see, you help them get better. And so the other thing they're talking about is they call self-prophy, where you teach people how to take care of their own teeth rather than having to come in, because traditionally, and again, because I'm older, I remember the history of what went on. You go to the dentist twice a year to have your teeth cleaned. If you're not doing a good job, then you go 3 times a year. And if you're not doing a good job, you go 4 times. And if you're really not doing a good job, they have you come in, and the definition of insanity is keep doing the same thing over and over again and hope you get a different result. So what we do in our practice, we have a microscope and we look at the bacteria in the mouth and how that's affecting the body, and looking at things that are related to it. So one of the interesting things about periodontal disease, one of the bacteria that causes periodontal disease causes platelet clumping. Platelet clumping makes your blood thicker and makes you more prone to blood clots. What is one of the real damaging factors of COVID? Blood clots. And so there could be a tie into that. And so they just looking at periodontal disease, and we'll get to airway in a moment, is maybe dentistry is more essential than the government claims, because I can fly to Georgia and get a tattoo. I can go to a spa somewhere. All the liquor stores are open, and I think that those of us who are doing dentistry or myofunctional therapy or nutrition are really a lot more essential. But somehow along the way we lost our way. So those are the challenges of what we're going to do. And it's an interesting story. So we have to wear these face shields in order to avoid splatter, but we wear these magnifying glasses that help us see better, and the shield won't fit against the glasses.
No.
So my son Jeff, who I'm lucky I work with my son and daughter-in-law, he rides motorcycles, so he got shields that they use for motorcycle helmets that are offset a little bit, that provide enough room between the face and the mask. So, as I said before, this is terrible times. You can either sit and wring your hands and say, "Woe is me, I hope that something will happen," or you say, "All right, what's going to be different about the world?" People are going to realize government, my medical system is not going to take care of me. I have to take better charge of my health. I have to seek out those practitioners who are going to be part of my team. And I'm going to establish a team of what I need. I know that you work with surgeons and other people in orthodontics in your area, because you realize the importance of a collaborative team. You know, somebody asked me what the definition of collaboration is, and somebody says, well, I'm taking care of a patient, and this patient, and no matter what I do for them, isn't working out, and I'm sitting, how do I get them out of my office and send them to somebody else? Who can I collaborate with? Well, that's not really collaboration. That's sort of offboarding. Collaboration is at the very beginning of treatment, as you're having that initial visit, that initial interview, saying, who should be on this person's team? Who do I need? What are my resources for this patient? Because if you establish that at the beginning, the patient is much more motivated. They're excited because you're doing something that nobody else has done for them before. If you do it later, then they're already discouraged that the results they expected to get, even though you may not have promised them. But even if you don't promise them, they believe that you're going to satisfy their every need. But putting together a team and having a way to communicate is really important. So then we should talk about airway and physiology.
Yes, let's talk about airway.
Let's talk about air. So are you a member of the IAOM?
I am, yes, I'm certified through them.
Okay. So a number of years ago, when they were at a meeting, one of our meetings, they said, you're not really giving us enough attention. I said, but it's in your bylaws that you can't talk about airway. That was about maybe 5-6 years ago.
Oh, yeah.
And I thought they would go away and never come back. But then 6 months later, they called and they said, we changed our bylaws. I'd like you to come to our meeting. And it's great because the group of people in that organization are fantastic. They're trained, they're tested, and if you're certified, people should know that you have jumped through hoops in order to get your certification. So airway is essential. What we look at is how do we get people to breathe and keep their airway open, because the number one thing that people want, number one physiological function, is to breathe.
Yeah.
Our physiology, our nervous system, is monitoring the way we are breathing every single second, every fraction of a second. That if we have less air than we need, the heart beats a little bit faster, blood pressure goes up. We measure something called heart rate variability, which measures interbeat heart rates. So that if your heart rate is, let's say, 60, you would think it's 1 beat a second, but it's not. It could be 1.1 second, 0.9 seconds. It's that variability that shows you're healthy. Variability shows resilience, the ability to adapt to things. If you look at posture, if I bend over to get something, I don't fall over, because as soon as the thought occurs to me, my brain says, these muscles have to tighten, these muscles have to relax. And instantaneously, more blood is sent to those muscles that need to be tight. Only those muscles, which is fantastic, and never consults us. It happens. What I learned some years back is, while I am concerned about how people get the air in, people who deal with speech deal with how the air comes out. Because without the exhalation of air, you can have no speech.
Yeah.
And then the other thing we look at is from a dental perspective, the airway is affected by if the tongue sits too far back in the mouth. Well, when you think about our tongue, it has to be one of the most incredible things, because what's it involved with? It's involved with breathing. It's involved with speech. It's involved with swallowing, and a little bit with facial expressions. So imagine somebody who has an airway problem, because when we talk, we don't say, I better stop talking for a second so I can breathe. We figure out how to pause and create pauses so that we can breathe. People who have an airway problem have their speech changes. They have more pauses in their speech. If they have a swallowing problem, speech, breathing and swallowing will come first, then speech will come later. So back in those years ago, I didn't understand how speech language pathologists really weren't looking at airway and breathing, which or maybe you're young, you may not remember back then, but now it's so essential to teaching people how to speak well, because if you don't deal with an airway problem, then you're not dealing with the whole problem. I was telling you before we went on this podcast about this great nasal breathing summit that we did a couple of weeks ago, where we had speakers from around the world, and one of our speakers was this ENT doctor from Massachusetts, Peter Catalano, who fantastic. Has written some papers. He works with an orthodontist in Boston, John Walker, and they're doing nasal surgery on young kids, or nose jobs on young kids. If they see that there's a nasal obstruction in young kids, they'll go in with a laser and reshape it or trim the bone or things that have to be done. And he's been doing it for a couple of years, because sometimes you can't get expansion of the arches if there's a nasal breathing problem. We're all very attuned to the importance of nasal breathing, production of nitric oxide, and there are some papers that show nitrous oxide reduces the viral load. They haven't shown it for the COVID-2, but certainly for COVID-1, it shows that it reduces the nasal load. So nasal breathing is really important. If you don't have good nasal breathing, you're not going to get good maxillary expansion, because if you're not getting air through your nose, your brain's going to say, I don't need it. It's not doing me any good. So I'm going to try to get more volume in through my mouth and build these nice vaulted cathedral ceilings. And so they've been going in and doing surgery on these young kids where appropriate, and fantastic results. So he said the most amazing thing was about 6 months ago, he got a email from a father of a patient whose kid was autistic, and within a couple of days after the nasal surgery, his autism started. It reversed. The kid is now completely gone.
Wow.
Since that time, and he wasn't treating autism. He was just looking for nasal blockages. But since that time, he has had 5 other children. I think it's 5. 2 or 3 with autism and 2 with really bad ADD. Nothing else was done but doing the nasal surgery and doing the rapid palatal expansion. So, you say, well, you don't do nose jobs on young kids because you wait until they get older, and it's more for aesthetics. But they used to say you don't do orthodontic treatment on young kids. You wait till all the baby teeth fall out and they're teenagers. So where do these rules come from? Somebody made them up, and then they continue because the heads of all the organizations that teach you say these are the rules. Now you go and you don't follow the rules. So becoming more certified tends to sometimes make you more narrow in your thinking. So I think that's really exciting about what they're doing with nasal surgery. And so in our office, we refer to a myofunctional therapist almost every day. That one way I could look at it is all of a sudden I'm getting all these people with myofunctional problems that I don't know where they came from, or maybe it's because you're looking at things with new eyes. A number of years ago, we gave a talk at NYU Dental School, and one of the professors from the pediatric dental department was there. Wonderful guy in practice, 35 years, very busy practice, never looked at airway problems. The next time we saw him 6 months later, he said, I can't tell you, I'm looking, I never knew I never looked at tonsils. I am sending people to back to the pediatrician, back to ENTs, having sleep studies done every day. I'm so upset of who I may have missed in 35 years of practice. And I said, you can't be blamed for not doing what you don't know. But once you know it, now you're responsible for it.
Absolutely.
And so I think that, we could chat about stuff like this forever, but I think the important thing is that this information needs to be shared and spread. It needs to be spread with our colleagues. We have to be less insular. We have to be less isolated. We have to go out and learn more, not only about what we do so we can do our part of the job better. We need to know what other practitioners can do. I mean, we work with myofunctional therapists. We work with physical therapists that when we talk about the autonomic nervous system, we are getting information from our internal body and our external body every fraction of a second. How do we know where our body ends and the rest of the world begins? We get input from our eyes, from our ears, from our teeth, from our tongue, from our hands, from our feet, just feeling the ground beneath us. We can make an oral appliance and change the way somebody walks. We can make an oral appliance and change the way somebody sees. Somebody can put on glasses with prisms, and it'll change the way they bite or the way they walk. Somebody can put different lifts in their shoes. It can change the way they see. Everything is so connected, and that if you can identify that from the very beginning, you know who needs to be on your team. I say, if a dentist walks into the room to greet their patient, they are missing a lot of information. They should watch them walk down the hall. How they walk, how they sit. Do they cross their legs? Do they always cross one leg over the other? Do they always, when they look at you, they tilt their head to the side? There's so much information, and the way people have certain posture will determine how the jaws and the arches develop. The arches develop, then their tongue will be off to one side, which will affect their speech. So I think I hopefully I gave you more questions than answers, which was my goal.
Yeah, no, this has been amazing. I mean, you've given us a lot of good information, and you're preaching to the choir, right? This is what I do every day. I have an amazing collaborative team. We're very thankful that the Natural Dentist Associates, which is our holistic dentist that we work with, and James Ryan, who's the oral surgeon that I also work very closely with. And I work with others in the area too, but they are two of my primary go-tos for my dentist and oral surgeon. They're very holistic, and Dr. Tipograph and Dr. Bear at Natural Dentist Associates, they do everything you described. I won't go back through it because you already mentioned it, but we put my daughter Lily into an ALF at just under 4 years of age. She was about to turn 4, and that was last August. And to see the tremendous growth and the change, and the fact that when they assessed her, they watched her walk down the hall. They took a video of her walking towards them. They took videos of everything to see. We say it changes everything from the tongue to the toes. And on that team, we've got the PTs who do modern counterstrain technique. And I'm also in a DNA myself. And so I've noticed firsthand how having those adjustments in office from the PT who's doing the modern counterstrain technique allows my maxilla to continue to move and expand. And because I have a partially turned in maxilla on one side, it's been amazing. It's amazing to see how that holistic team really works together. Like you said, from day one, not just when we hit a wall, but everybody needs to be in place day one. We need to have that functional evaluation. Everybody on the team needs to know what piece of the puzzle they're, playing into that patient's role, or what role they play in that patient's case. And yeah, it's been really amazing to see it both as a mother, but also as a practitioner, and as a patient. I've been able to play all three of those roles. So I love how this whole, the collaboration that you speak of that's a big thing I talk about constantly on the podcast.
That if it was only me talking to you, I probably wouldn't be doing this, but I know that there might be other practitioners who will hear this.
Yeah.
And members of the public, because when I talk about collaboration and building a team, the patient is part of that team. They're not,
yes.
You don't do something to or for a patient, you do it with them. They need to be an active participant. And when some people enter this world of better airway and breathing, they may not do it through a practitioner. They may say, let me go and get one of these nasal dilators, like a mute or something, or let me try taping my mouth or something. That we live in a generation where people aren't running to practitioners. They're trying more home remedies.
Mm-hmm.
They may even try a over-the-counter sleep appliance, which is fine, because anyway, they say, I am noticing if I'm breathing better, I'm feeling better. Let me then take the next step. So there's no one treatment that works for everybody. And knowledge is important. My daughter is an acupuncturist, craniosacral therapist. Great. She basically works with mothers and babies before, during, after birth. She does craniosacral therapy on 1-week-old babies, and you can see the difference in the way they nurse. When she had her first child, and she was breastfeeding Mackenzie, everything was fine, no problem. It took maybe half hour or whatever. Then she had a second child, 5 minutes. He was done. She never realized that when she was nursing her first child, that there was some problem, and it turned out that she developed a narrower arch, and then we put her in some early expansion at like age 3 with some craniosacral work. But she said, "I'm smart. I know this stuff," and I never thought. She said, "I wouldn't have known that my breastfeeding wasn't what it should be until I have had my second child and had something to compare it to." So getting this information out, not necessarily so you can promote your practice and getting people in, just sharing information so people can be healthier. And as I said at the beginning, teaching them how to take care of themselves is really the important thing. That ideally we should be so successful that we have no patients. But it won't happen. Don't be afraid, because it won't happen in our lifetime.
Yeah, no, I know you have patients to get back to, so I won't keep you too long, but that was the whole point of this podcast. It's funny because I went to look for it as a mom who went through that same experience as, your daughter. And with my first one, not knowing it was an issue until I had my second, but also until Lily was already 2 and I looked under her tongue after getting my certification in orofacial myology and went, holy cow, she has a tongue and a lip tie. And I was turned away by all these practitioners. So there was the passion project behind it and educating other moms and practitioners, but there was also the fact that I went to look for this podcast and nobody had created it yet. And so I said, we need something that talks about myo and airway and tethered oral tissues. And since this is the nosedive that I've taken, like I said, as a mom who's a mom to these kids, the patient who's going through adult expansion after orthodontic relapse, and the practitioner who is treating everything from feeding therapy with babies to myofunctional therapy, you know, as well across the lifespan, this information needs to get out there. And so that was what birthed this podcast in July of 2019.
Let me tell you one more story about a patient, and then
yeah, absolutely.
Okay, so there's a patient who came in to see us. She's in her 50s, and through a divorce, a lot of stress, and developed terrible pain. She works in an office, not in the same building as us, and one of her teammates brought her in and said, "You can fix her." So we just injected the trigger point and relaxed her muscle spasm, but she had a TMJ problem. And we said, you know, you have a very narrow arch. Her molar distance between her upper first molars was 23 millimeters, which was, we know it should be 38 to 40 millimeters. And she had an incredible tongue tie. And so we said, all right, you know, we have to release that tongue tie because that probably contributed to you developing this narrow arch. But how can you learn to put your tongue in the right place when your arch is so narrow? So what do you do? What do you do first? You know, so we had got her to see a myofunctional therapist to learn the exercise, which she couldn't do because she had no place to put her tongue. And then we said we're gonna make an expansion appliance, but it didn't fit. So we had to instead of putting it with one screw, we had to put 2 mini screws in just so we can make it wide enough so we get a bigger appliance in order to do that. And then we got her to about 30 over a period of maybe less than 35 millimeters, which is tremendous. Now she had a little bit more room. And then we had she went and had a tongue tie release, and which was videotaped, and everything just relaxed at the time. And it was like a miracle. She continued to do her exercises, but had some more stress in her life, and then didn't necessarily follow them. Things scarred down a little bit, and then the next thing that happened is she said, "My tongue is all over the place. I don't know what to do with it." And because she still didn't have enough expansion in her molar area, but she had more room in the front, so it kept coming forward. And then we were orthodontically trying to close her anterior open bite, but couldn't because her tongue, which was now looser, was causing a problem. And now we're looking at sending her for nasal surgery because she has a really bad deviated septum, and the side she can't breathe on is actually the side that she has a TMJ problem, which we always find that the side where your nasal breathing is poorer is the side that you have the problem on. Mm-hmm. And there's a lot of times when you use an ALF or an expansion appliance, and one side expands more than the other, you should look at whether there's a difference in the nasal breathing. That could affect how things are expanding more one way or another. But the point is that even when you know the parts you want to put together, the sequencing of it is important. And it's so much better if you find out what you're missing at the beginning than to try to figure out, all right, why isn't this working? So can I give you my sales pitch?
Absolutely, go for it.
So it said on my little instructions that I can promote one thing. So I'm going to
promote two. Go ahead.
So I'm involved in 2 organizations. One is the AAPMD, the American Academy of Physiological Medicine and Dentistry, and it's a membership group of professionals where if you are concerned about airway and breathing, and whether you're a physician, dentist, myofunctional therapist, nutritionist, chiropractor, anyone, you have an equal seat at the table because everybody has something. And the goal is to learn how to network together so that we have courses about everything. We have a meeting scheduled in November. We have no idea what's going to happen in November. It's in Seattle. And it was originally going to be for 3 days. We've added a day. And one of the features we've added to that is we're going to have a whole day put on by Suresh Zaghi from the Breathe Institute. It's called Outlook. They're going to talk about the latest research. And we're going to have people come and submit research projects they would like to do. So we have things for every practitioner, but we have modules where different practitioners talk about how they work together. So that's great. And then we develop, you might be interested in this, Hallie Narouche, who manages Dr. Zaghi's office, and she's a board member of our AAPMD, put together AAPMD liaisons, forming study groups within different areas in order to help promote the message. So that's AAPMD. People can join aapmd.org, and maybe you put that up on
yeah, we'll put that in the show notes so that they have access to that link. And then tell us also about airwayhealth.org.
Okay, so then the second organization is the Foundation for Airway Health. We thought when we formed the APMD, this was going to change the world. You know, I don't have lofty goals. I just want to change the world. But we realized that it's not practitioners who are going to change the world. You know, the vast majority of orthodontics don't even look at airway. And they will change when nobody will go to them. And people won't go to them if they learn how important airway is. And so we said we need to get mobilize the public and get them to get behind this and learn to be wise healthcare consumers, to take charge of their health. So we formed the Foundation for Airway Health, which is really for the public. We have things called white flag events where we try to bring different people together. One white flag event, we had 23 people representing different orthodontic philosophies, all who had 7 minutes to tell us why their philosophy was best. And at the end of the day, what could we agree on? That airway was important. That they may not like each other or may think their appliance is better, but they all believe that airway is important. And if there was only one appliance that worked, then there wouldn't be all these other options. And I always say that to what we say is, if you go to somebody who only has one tool in their toolkit, you know, you could put a screw in the wall with a hammer. That doesn't necessarily mean that would be good. So the Foundation for Airway Health, there is no membership fee. Anybody, any practitioner can go on the Foundation for Airway Health, say that I want to be an airway advocate. They can fill out their information, and they can be listed as a resource for people seeking care, because we get visitors all the time who are looking for somebody in their neighborhood. They don't know how to find somebody. So we want to educate the consumer, raise awareness, provide education, and then provide resources, because if airway is important, which it is, everybody has the right to a better airway. Not everybody can afford, you know, ALF and DNA are expensive treatment. Mm-hmm. What about somebody from a lower socioeconomic group? How do you deal with them? When you say, well, you know, you could have a better airway, but you don't have the money to afford it. We were in Washington, D.C. We met with, there are 5 U.S. congressmen who were dentists. We met with them to try to get them to try to put programs in place. So how would you deal with somebody who is economically challenged? Early intervention, because you can get a 3-year-old, put an expander in that, and then their bones are like mush. They just move. You recognize that. You get expansion. So we encourage you to become a member of the AAPMD. Get yourself listed on the Foundation for Airway Health, and be active. Be active in your community. If you have a successful practice, you owe it to the world to get out into your community when it's safe. You don't have to do it now. When it's safe, get out into your community. Encourage others to seek help. There are community groups, there are churches, there are synagogues, there are parent groups. They love information. Everybody can be a speaker. We will train anybody to be a speaker. We will give you a slideshow for this. We want to change the world, but we can't do it without you and all the people like you. And that's my sales pitch.
I love it. And that's great. And I did join the airwayhealth.org. I think it was last summer. And I was looking at the AAPMD to join last night as I was reading through our pre-show notes. And it's definitely needed. It's been very well received also by our early intervention speech pathologists and OTs. I've gone and I've spoken to them about, as well as Walter Reed, which I live across the street from. I was able to go and do a whole, talk on just airway and myofunctional disorders and how we pre-screen. What do we look at in the birth to 3 population? What can we do for them now? We don't want to wait till they're 6 to 9 years of age when most of the traditional orthodontists in the area will expand them. We want to know how can we help them now?
I think what we don't realize is that once we become smarter and we know all this stuff, how many people don't know anything?
Yes.
You tell somebody, you have a tethered frenum. What's a frenum?
What do you mean that finger under my tongue? I thought that was normal. Or, I thought snoring was normal. Or, I thought, well, no, it's common, but it's not normal.
You have a narrow arch. What's an arch?
Uh-huh.
That we assume things.
Yes.
And then what's the first thing that happens when somebody doesn't know something? They shut up and they don't ask a question because people are afraid of saying, I don't know.
Mm-hmm.
But every one of us lived in a time where we didn't know.
Yeah, and there's always more to learn. We constantly encourage everybody on the podcast to be okay with saying, I don't know, and seek that information and, keep growing.
I really enjoyed our time together. I do have to run off and see an emergency.
Well, thank you, Howard.
It's going to take me the next 10 minutes to change and put on all my protective gear. And so thank you very much. And I look forward to seeing you at a meeting somewhere once it's safe in the world.
Absolutely. Thank you so much for joining us today.
Thanks for listening to this podcast. If you want to hear more of these Myo, Tots, Airway, and feeding related episodes, be sure to leave a review on Apple Podcasts or pledge a small amount on patreon.com/the Untethered Podcast. If you found value, others in this space will too. So be sure to share this episode on your social media platforms and join us over on Facebook, on my Facebook page at Hallie Bulkin Biz, on Instagram at Hallie Bulkin, and you can head over to theuntetheredpodcast.com to grab a copy of the show notes, where you can also subscribe to be kept up to date on the latest podcast episodes.